I don't have a slide with my disclosures. I think probably it's my 9 hours of jet lag, probably forgot to put it. But I hold several patents and I receive royalties for using the NMDA receptor, MA, and GABA-B as diagnostic tests. I don't think this influences at all what I'm going to say, but just to clarify this. I'm going to talk about the autoimmune encephalitis and in the context, and I think that this slide summarizes a little bit why there has been such tremendous interest in the new types of autoimmune encephalitis, not only paraneoplastic but also the non-paraneoplastic. Encephalitis, as you know, is an inflammation of the brain with a complex differential diagnosis, and what is striking nowadays is that there is still in many places around the world, and about 50% of the patients, we have no clue about what the patient has in the hospital, and we have no idea what was the cause or what is the cause of the encephalitis. We have all these patients in the hospital. We know that when they call us or colleagues from the ICU and so on. And so in this context, then we start thinking always about this could be autoimmune or not, and this has popularized also this field that nowadays, since 2007 until now, we have 16 disorders in which, let me clarify this, in which the patients have antibodies against a cell surface protein or against a synaptic receptor that is accessible to the antibodies. Okay, so here you have all 16 updated just a few days ago. There are some that have, at least one hasn't been published yet, the Neurexin 3 alpha, and these are the ones that these went from here. The last 4 are all cerebellar degeneration, so one that associates with a sleep disorder. And these ones here are the ones that can associate with encephalitis. Some of them are quite uncommon, and other ones are becoming more common as people know them and the studies are accessible. So I'm going to talk a little bit about some of them, not all of them. There is no time, and it's better to concentrate in a few and probably clarify some ideas or issues than to try to go through all of them. There is literature on this, there is reviews, and I'm going to give you later also one citation, one reference. This is how all these antibodies, well, not all, this is how 13 of these antibodies are seen when you use a section of rat brain, and the tissue is prepared especially to see cell surface or synaptic receptor antibodies. These nowadays seem pretty simple, but before 2007, basically, if you test this for the classical, using the techniques for the classical paraneoplastic antibodies, most of them would be negative. But there are some of them with these techniques that even just looking at them with the tissue staining, you can predict, or you can already tell what's going to be. The pattern is so characteristic that helps very much in the context. It's usually more in the context of research. In some places it's been done in a clinical lab. But they are no subtle. This is not something ambiguous. You can see them quite well. And it's not subtle at all when you, instead of peroxidase here, we use fluorescence. And this is one of them. But what I want, this is one here, is the NMDA receptor antibody. But what I want to describe here is the pattern more than the specific staining. But the pattern is a pattern that stains the neuroapical brain rather than the neurons, individual intracellular proteins. Since it's on the cell surface, it looks like a punctate-like staining is a synaptic receptor, and the neurons seem to be actually not stained, just on the surface. You cannot see this very well here, but you see here in cultures of neurons that are live, and you see the antibodies reacting with the cell surface. This is, for example, the AGU or ANA1, and just you can see them here because the tissue is permeabilized and fixed, but with live neurons you don't see anything. you use this as a marker of the nuclei to convince you that in here there are neurons. It seems very simple, but conceptually is very interesting, because when these antibodies started being discovered about 10 years ago, immediately suggests that this is an antibody against a protein. It's on the cell surface. So if you get rid of the antibody, probably you're going to be more lucky, or the patient is going to be more lucky in recovering, that if you try to treatments for these disorders, in that we have seen from the previous speakers that the main effectors are the cytotoxic T cells, and you can plasma change these patients, but the cytotoxic T cells are the one that cause the symptoms. One of the most studied of these disorders, because probably was the first identified, is the NMDA receptor encephalitis. And this, when it's well characterized, it means like when you really define the antibodies clearly, they are always in the CSF, and many of them also in the serum. And the patients, most of them have a syndrome that is like this when they have a full-blown syndrome, or is a fragment of it. Many patients present with a prodromal syndrome and then evolve very fast towards a situation of coma, hypoventilation, and other autonomic dysfunction, and usually at the beginning present with a lot of psychiatric manifestations, agitation and catatonia, memory deficit, speech reduction that sometimes is described like aphasia, but it's not. It doesn't fit with any type of aphasia. The kids are usually children become actually almost mute, abnormal movements and seizures, and usually the patients recover usually from the abnormal autonomic dysfunction, start getting better, and then they are left with a lot of still executive dysfunctions that can last for a long time. And they usually don't remember these. They don't remember anything. Not only when they were in coma, of course, nobody remembers that. But in the months preceding, in the months after being in coma, when they are recovering, you can have conversations with them. They're really reasonable conversations and so on. But they usually don't remember these. And of course, the NMDA receptor is essential for forming new memories. So that's probably the reason. This is a paper that that we did. Martin, actually, Dr. Tito Lair, followed all these patients that we had collected in several years in the Penn and University of Barcelona. And basically the points here is that most of these patients these 577 patients, and most of them are young. So the median age is around 20, and most are younger than 50. Of course, there is always a patient that had he was in the 90s, and about what's interesting is about 36% are children are defined younger than 18, and the youngest is 2 months old. And the dark columns here, the dark red column is the women with teratoma, and the dark blues that are here barely visible are men with tumors. And the light colors are men or women without, the blues are men without tumors, and the light here, the pinks, women without tumor. So if you have a patient that is very young, probably you don't have to insist very much in finding a tumor. It's just you can look at it, but not really. It's not like the insistence that you have to put in a patient with a Jew that is a smoker and has a sensory neuronopathy that you know is going to have a small cell lung cancer. In here the situation is different, and then basically what one of my colleagues told before in young women, but adult women basically almost 50% have teratomas. This is just to show, I'll show you the treatment later, but many of these patients do quite well with treatment of the tumor if it's identified, and with immunotherapy, with first line and with second line. I'll tell you later. But what you see here is that the patients have relapses, like in many autoimmune disorders, and about 12% of patients have relapses during the first 2 years. And what in here shows is that if the patients that don't have tumor, they have more tendency to have relapses than the patients that they have tumor and receive the whole entire treatment, removal of the tumor and immunotherapy. Some of these patients may have an occult tumor, but not all. And there are people that they have been doing ovaricectomies, blind ovaricectomies that we never recommend to do, and then sometimes they have a microscopic tumor, and many times they don't have anything. So it's just flipping a coin. You don't know exactly what to recommend in these patients. And at the same time is that the relapses in some way also correlate a little bit with the type of treatments. The first line is IVIG, steroids, or change. And the second line, which is the dark green, as rituximab and or cyclophosphamide. So these are the ones that have less relapses, the ones that are more intensively treated compared with the first line alone or not treated. There are patients that recover spontaneously. So this is a little bit about NMDA receptor encephalitis. You're going to hear more later, and the psychiatric manifestations, and tomorrow you're going to hear more in terms of the base mechanisms in the COTSIAS lecture. I just want to talk a little bit about some of the others and some clinical clues that may help. The NMDA receptor encephalitis is per se like a syndrome, right? That was not identified in the past, but now we can see a theme in all the patients when they are the diagnosis is well established. For the patients that have antibodies against LGI1 or AMPA or GABA-B, they don't have really an original syndrome like a signature, and they basically have many of these patients, not all, but many, they have a classical limbic encephalitis. And you have 3 cases here you cannot tell apart clinically and just looking at the MRI. What it helps is the accompaniments. For example, LGI1 is more predominantly a bit more in older men. Usually almost never have a cancer. If they have a tumor, it could be a thymoma, but it's very uncommon. Sometimes they have hyponatremia, well, sometimes not, almost 60-70%. They can be preceded by facial-brachial dystonic seizures. These ones, for example, they can manifest the same way neurologically, but these patients with AMPA receptor, they are 50-50 men, women. The distribution is more or less 50-50, and about 70% of these patients have actually cancer, have breast cancer or lung cancer, or they have thymoma, malignant thymoma. The interesting thing in these cases is that the patient responds to immunotherapy despite having a highly malignant tumor, compared with a counterpart that you may have, for example, a classic limbic encephalitis with AGU. And so the patients, you have the same syndrome, even the same tumor, but the immune response is different. So, but the linked autoimmune disorder is different, and the immune response is different. But in all these syndromes, you usually have a tendency to improve with immunotherapy. In the GABA-B, basically 50%, a little bit more of these patients have small cell lung cancer. And here again, here applies. These patients, you treat immunotherapy on the patients, and you remove the tumor, or you treat the tumor with chemotherapy. They usually they do well. Interesting one, and this is like a clinical pearl, is that the GABA-B, the GABA-A receptor encephalitis is not really, doesn't have any specific syndrome. It's not limbic encephalitis. But the clue, and we have confirmed this in a study that we are finishing, is about 65-70% of the patients have this type of MRIs. Have an MRI with a cortical, subcortical flare abnormalities that during the course of 2 or 3 weeks they are popping in and out. And this is quite characteristic. Almost you don't see this with any type of other type of these cell surface autoantibodies. I just want to clarify the concept of voltage-gated complex, voltage-gated potassium channel complex antibodies. What it means is that includes the LGA1 and the Casper2. We really like very much to specify the type molecular target, LGA1 or Caspr2, because if these patients are negative for these ones and the voltage gated complex antibodies are positive, you really don't know what you are dealing with. And when we get some of these cases to clarify, if you put these on cultures of neurons, they don't react at all with the cell surface. They are not against the potassium channels. They don't know really against what it is. And associates with many different disorders, and even in normal individuals, although this is much less, proportion is lower. So be careful with this. So you want to specify with the LGA1 or Caspr2, and these associated with a specific type of syndromes. There is a paper that is under review by your groups. Martin is the lead of the paper, in that there is a core of symptoms with Caspr2. They usually have the flavor of Morvan syndrome, and in this study there are 38 patients. 77% had more of these, 3 or more of these symptoms, like cognition, epilepsy, cerebellar symptoms. Peripheral nerve hyperexcitability means neuromyotonia, which in this context with the other symptoms would be like a Morvan syndrome, autonomic dysfunction, insomnia, neuropathic pain, and weight loss. 90% have thymoma. Essentially, that was the tumor that was identified. Another disorder that is quite interesting. In here, you don't have you don't have a specific syndrome, but there are some clues that should lead you to suspect that. Dipeptidyl peptidase, like protein 6, is what's called DPPX, is the abbreviation DPPX. Is not the potassium channel, is a subunit that associates with another entire different family of potassium channels. And these patients develop a syndrome of hyperexcitability, sort of like become agitated, sometimes psychotic, with tremor, with myoclonic, you don't know, it looks tremor, looks myoclonus, with some sort of nystagmus. And usually these are preceded by diarrhea, and usually with a lot of loss of weight. And actually Mayo Clinic also did a study of a number of patients, I think were around 20, and they found also this tendency to have this prodromal diarrhea, loss of weight, or GI problems. Many of these patients are heavily investigated for cancer, and they don't have cancer. Most of them, or they have a lot of investigations to find GI problem. Usually is not found. The antibodies react with the mesenteric plexus, in addition to react with the potassium, with this subunit that interacts with the potassium channels, this protein in the brain. This is one of these patients, and this disorder is extremely respond quite well to immunotherapy. This is one of these patients, courtesy of Dr. Michael Walsh, and I want to show you the segment that comes now a little bit. It's hard to classify. You would say, okay, this patient, particularly here, is the same patient recovering. You would say it's Parkinsonian, right? And this is the same patient. A few from here to here is like 1.5 years. And the patient, when the steroids are decreased, she develops again the symptoms. And usually these patients do well. So it's worth to identify. So let me go to just a few things. One is that in addition to tumors, what's becoming interesting and hot, particularly with an MDR receptor, is that patients that have herpes encephalitis and a few weeks later come back to the hospital, sometimes with what used to be called chorioatetotic post-herpes encephalitis, post-herpes simplex encephalitis. It's suspected to be a relapse. And nowadays we know that these patients, most of them, they have an autoimmune encephalitis mediated by the NMDA receptor. This is one of these kids, the first one identified with that. And is in the stage of sort of relapsing symptoms post herpes simplex encephalitis. The herpes simplex encephalitis deficits or lesions in the brain were brutal in this little girl. She had bilateral necrotic lesions, but on top of this developed this autoimmune encephalitis, and when it was identified, it could be treated, she could be treated with immunotherapy, and she did quite well. And this is what happens with a recent series of patients that they have this problem. When you, it's a beautiful model, think about it. You have a patient with herpes simplex encephalitis, you prospectively follow this patient, you don't know what they are going to develop. They don't have antibodies during the herpes simplex encephalitis, and a few weeks later, when they develop the syndrome, they have the antibodies. So the virus triggered that. By molecular mimicry, we don't know. By destruction and inflammation and presentation of the antigen, perhaps. But it's quite interesting. It's worth to recognize. And just remind you that some of these syndromes are not pure sometimes. You can have encephalitis, NMDA receptor encephalitis, mixed with NMO or NMO spectrum disorder, both together, which are difficult to identify, or alternating in the same patient. This is uncommon, but it happens in this study that we did, Marty did also when he was with us. And these are some examples. All had NMDA receptor encephalitis. This one had aquaporin 4. In addition, this one had was aquaporin 4 and MOG negative, had one sort of demyelinating lesion here. And this one is a child, had MOG positive NMO spectrum disorder plus NMDA receptor encephalitis. In these cases, are two disorders at the same time. It's worth to know how to treat them. And it's also worth to know, although I'm not very fan of testing the patients for all antibodies, I'm not really very fun to do that. I like very much to examine the patients and have a clue and then try to select. But sometimes it's important because sometimes you find several antibodies. In this case, this is a study in patients with AMPA receptor encephalitis. Remember that the AMPA antibody is associated with cancer. Well, it makes a big difference if the patients have, on top of the AMPA receptor antibodies, if the patients have an onconeuronal antibody, like EGU or CRMP5. These patients, they don't do well. However, with the same type of tumor, if they only have AMPA receptor antibodies, they do much better. Well, they recover, many of them. I want to finish with answering a few questions that sometimes come. One is when to suspect these disorders, how to make the diagnosis, how to treat them, and when to stop treatment. When to suspect? Well, with a rapidly progressive encephalopathy of unclear etiology, usually it's multifocal, it's not like a pure symptom, like abnormal movements only, or psychosis only. They can present like this, but usually evolve and progress fast to present other symptoms. Then, well, of course, if there are inflammatory findings in the CSF, it's supportive. It doesn't give you the diagnosis. A viral process and other things can do the same, but it's supportive of an inflammatory, perhaps autoimmune process. And then, as I show you, in some cases, the MRI can help, can sort of suggest already what could be. If you have a bilateral medial temporal lobe flare signal, increased signal, and the viral studies are negative, you don't need the antibodies to start the treatment. You can just go ahead with it. How to diagnose? Well, in some way, to just the clinically oriented diagnosis, consider the syndrome, the age, gender, study serum and CSF. For these disorders, the CSF is critical. This picture of all these beautiful brains stain, all are done with CSF. All the identification of these disorders started, we started like 10 now, identified 10. All usually started classically, historically, when we made the initial observation, started with the CSF. This doesn't mean that the serum doesn't have the antibodies, but I want to clarify this. So just be comprehensive for these disorders, study serum and CSF. And then consider false positive results with these type of antibodies. Is only the serum is positive. When you follow these patients with tissue staining and so on, many times are false positive, if only the serum is positive. And the antibody titers are very helpful the antibodies are very helpful to make the diagnosis, but following the titer should not guide to make clinical decisions. They are not very good. And the patients can recover despite of being pathogenic and still have antibodies. And just think a little bit like in myasthenia, okay? In myasthenia, you don't treat the antibodies, you treat the patients go home, still can have acetylcholine receptor antibodies. This is a recent paper by many authors, and the reason that we designed this paper is just to avoid the concept that, okay, this patient have an encephalitis, let's do the laundry list of all the antibodies, and let's wait. And so I think that for some of them the clinical picture is highly suggestive, and this is the origin of this paper. And the paper also discussed the caveats of the antibodies and so on, but it's more clinical, and so it may be helpful. And then how to treat? Well, check for the tumor, treat the tumor. This is not written in stone, this is experience, this is how it's been done. It works mainly for an MDR receptor encephalitis, seems to work for many of the other ones. Use first-line therapies, IVIG and steroids, or plasma change. Consider second line if the patient does not improve, and there is no data showing the utility of steroid-sparing drugs for chronic treatment at this time. This is a graph that Martin put together with, and this is how most patients with NMDA receptor encephalitis are being treated by us and others. Usually you start with IVIG and methylprednisolone. You wait a little bit. If there is effect, yes, so then you watch and wait, and then after 1 month you consider to repeat. About 50% of the patients, they follow this pathway. Then depending on the age, if they don't respond, if they are older than 16, you can be more aggressive. We like to combine both, rituximab and cyclophosphamide, and then check if there is B-cell depletion. If there is depletion, then just continue with cyclophosphamide for about 4 or 6 months. If there is no depletion, repeat the rituximab. In young people, of course, and young children, patients, there is a tendency to use more rituximab and don't use the cyclophosphamide at the beginning. If it works, watch and wait, and then if not, then scale to cyclophosphamide. And then when to stop treatment, that's the most tough question, I don't know, and in these disorders. It was very nice what Dr. Klein said, that all these peripheral neuromuscular disorders are very quantitative. You can follow these, you can make decisions. In this case, the antibodies are not a good guide. I would be treating patients now that they have been already, went back to the university, they finished the studies, and they are having a nice life, and they still have antibodies at low titer. You have to follow clinically the patients. At some point make the decision to stop when the patients have recovered significantly. And then some other tests, maybe a guidance for treatment, FDG PET, and probably advanced MRI, studying connectivity, resting state functional MRI can be helpful in the future. And then consider the clinical setting. There is preliminary evidence suggesting that initial comprehensive immunotherapy prevent relapses. Thank you very much.